Hi, my name is Julia Puebla-Fortier, and I am the project director for the Your Voice webinar series that's sponsored by DiversityRx. We're very glad to have you here today for part of our monthly series on good practice and policy and research in the service of improving healthcare for culturally diverse populations. So what I'd like to do at this point is run you through some introductory information so you know how the webinar is going to work. But before I get into the technical details, let me just tell you a little bit about DiversityRx. We're a nonprofit organization that works on a variety of different projects, from policy development to research, and in particular education and support for people who work to improve healthcare for culturally diverse populations. Among the projects that we run are the DiversityRx website and the Class Talk listserv, and we're also the co-producers of the National Conference Series on Quality Healthcare for Culturally Diverse Populations. And, of course, the Your Voice project is part of the work that we do and the sponsoring project for this webinar series, which you're on today. So what I'd like to do on the next slide is to take you through a little bit of information about how we're going to handle Q&A for this webinar. As you know, we're going to start out with introductions, and I will turn things over to our guest moderator today, who will introduce our panelists, and then we will have our presentations back-to-back from each other. And because there are so many people on this webinar, more than 1,200 people actually signed up for it, it's not really possible to have people speak on the phone and give us their questions. We know we won't be able to get all of the questions that are on your minds during this webinar, but you do have the opportunity to type in your questions. You can submit them at any time using the questions window, which is at the bottom of your control panel. And if you'd like to, when you type in your question, you can indicate whether you want your question to go to a particular speaker or whether it's just a general question for any of the panelists. So just as a reminder, you are muted throughout the entire presentation, but of course you will hear the speakers and you'll have a chance to type in your questions. A little bit more visual is the little diagram you have on the right side of your screen. So when you want to ask a question or make a comment or even suggest a resource to the organizer, enter it into this question pane, and we'll forward the questions to the presenters and try to answer as many as we can. It won't be possible to get to everybody's questions, but one of the things that we do commit to doing is keeping track of all of the questions that you type into us, and then putting those to the panelists and the moderator after the webinar is over, and they have very graciously agreed to try to answer a selection of them, which once we put that together, we will send it back out to you after the webinar is over. So on the next slide, just remember that a little technical trick here is that you want to keep track of the GoToWebinar control panel. So if you go over to the right side of your screen right now, you can select View from the drop-down menu, and then make sure that it doesn't have Auto Hide the Control Panel, which is that text that you see in blue, clicked. If there's a checkbox next to it, or a little check by it, then your control panel will disappear, and you might not know where it's gone during the presentation, and that might make it a little bit harder for you to find the question pane. So make sure it doesn't say Auto Hide the Control Panel. Now, to move on to more of the substance of the presentation, this webinar is called Health Literacy, Using a Self-Assessment Tool to Guide Quality Improvement in Primary Care. And we're very pleased and honored to have Cindy Brock from the Agency for Healthcare Research and Quality as our guest moderator today. And she's done a lot of the work in putting together this session and selecting the panelists, and she's really a national expert on cultural competence and health literacy issues, and does quite a bit of policy and research and advocacy work, advocacy of the issue through her position, both within the U.S. government as well as on a national level. So I'm very, very pleased to turn things over to her, and she will introduce the panelists to you and get us started on our presentations.
Thanks so much, Julia. And I first want to thank you for the opportunity of addressing this audience. I think we probably have a mix of people here. Some of you are very steeped in health literacy, and some of you probably this is a new term for you. So I'm going to start out giving a little bit of an introduction, beginning with the definition of health literacy. And that is not the right slide, so I'm going to bear with me for a second. There we go. So the definition that is up here is from both a Healthy People 2010 objective, which is the Department of Health and Human Services goals for prevention and disease treatment. And it has also been adopted by the Institute of Medicine in its report on health literacy. And you can see it's a very broad definition. It talks about individuals' ability to obtain, process, and understand healthcare information. And you'll notice that it's not limited to just comprehending written information, but it includes verbal communication as well. So I'm going to start here with a little bit drawing the connection between the world of cultural competence and serving diverse populations and health literacy by looking at the prevalence rates. And on the far right column, you'll see a measure of health literacy for the whole U.S. adult population. And people were assessed through something called the National Assessment of Adult Literacy, which created a special health literacy measure, which was really a measure of literacy in a health context, and rated people as being proficient, intermediate, basic, or below basic. And I should note here that the term proficient doesn't mean, this out-of-this-world concept. It's really based in an educational sense of proficiency, meaning like you're proficient enough to go to the next grade level. So we really want the entire population to be at the proficient level. But as you can see, we only have 12% of U.S. adults being proficient, meaning that 9 out of 10 adults may lack the skills they need to manage their health and prevent disease. Now, the columns to the right of the total column show you that there's huge variation based on race and ethnicity. So, for example, Hispanics, 2/3 of them are not reaching the intermediate level. They're down at that basic or below basic. And intermediate level, so that you have an understanding of what kind of tasks we're talking about, an intermediate task would be understanding the correct dosage of a drug based on reading the over-the-counter label. So 2/3 of Hispanics aren't reaching that level, over 1/3 of black adults, almost half of American Indian, Alaskan Natives are not reaching the intermediate level. Now, although that measure, which was done in 2003, is measuring the individual's skills and capabilities, I put up this slide to underscore that health literacy isn't just what the patient brings to the table, but it's the product of that individual's skills and abilities with what kind of demands we place on that patient, the complexity of the health information that we present. And those two things combined are what's going to create understanding and ability to use health information. And I want to point out that, I think that our audience here represents some people from the health literacy world, some people from the cultural linguistic competence world, and that there's really an overlap between these two approaches, even though they have a different history and use different techniques. So, for example, TeachBack, which is a health literacy tool. It's used to help clinicians confirm understanding of patients by asking them to repeat back in their own words what they took away from what the clinician said. So if you gave them instructions, you'd ask them, what do you do? What are you going to do? That is also a very effective tool for confirming understanding with patients who have language barriers or cultural differences. Similarly, cultural competence techniques can be used successfully for improving communication with patients with limited health literacy. So, for example, there are questions that are called the Kleinman questions that ask patients what they think their illness is, what do they think caused it, what kind of treatment is going to work. Those kind of questions, while they were developed to elicit cultural health beliefs, are also very effective for assessing what patients with limited health literacy understand about their illness, how their body works, what kind of treatments are they thinking how those are going to work. So this presentation is put together about a toolkit that we developed to address health literacy universal precautions. And I just wanted to spend a moment kind of explaining what do we mean by universal precautions, because we stole this idea from basically the infection prevention field, where I think many of us that will resonate about universal precautions that we take so that we don't spread infection. And the theory is that you don't really know who's infected. You don't know whose blood is tainted. So you're going to treat every patient universally as if they were infected. And so we have the similar idea with health literacy, that we can actually structure the delivery of care as if every patient had limited health literacy, because you can't tell by looking. I mean, some patients with limited health literacy have completed high school or even college. They may be well-spoken. They may look over written materials and say they understand. They might hold white-collar jobs or healthcare jobs. And what's more is everyone can have difficulty understanding things some of the time. So if you're stressed by a new diagnosis or a whole bunch of information, your health literacy may go down. So we developed this toolkit because we felt that healthcare providers out there are getting to the place where they are aware that health literacy is an issue, that some of their patients may be having difficulties understanding and caring for themselves as a result. And we've gotten to the point, we think, of where people are asking, okay, I get it, but what do I do about it? So we understand that practices are extremely busy, that there are competing demands. And so ARC, my agency, the Agency for Healthcare Research and Quality, commissioned this Health Literacy Precautions Toolkit. And we used our practice-based research networks to get a group of researchers and practitioners who really understood both what it's like to work in a busy practice, but also what is the potential for improving health literacy. So without further ado, I'm going to introduce our panelists, and I'm just terribly excited about these two. They're going to be presenting in a sort of tag team fashion. So what we're going to do is have both of them speak, and then at the end we'll try and address the questions that you type in. So Dr. Darren DeWalt is an assistant professor in the Division of General Medicine at the University of North Carolina at Chapel Hill. He's board certified in pediatrics and internal medicine. And Darren is the director of the evaluation for the IPIP project, which is Improving Performance in Practice, and that's a practice coaching intervention to improve healthcare delivery. Most importantly, for the purposes of our webinar, he's the lead author of this forthcoming toolkit, and he developed the health literacy practice assessment tool that he and Laura will be speaking about. Our other panelist is Laura Noonan, and she's a member of the pediatric faculty at the Levine Children's Hospital at the Carolinas Medical School. And she serves as director for the Center for Advancing Pediatric Excellence, the Quality Improvement Division for the Levine Children's Hospital. She's also a senior improvement advisor with the Charlotte area health education centers. And Laura, our prediction is that all of the questions are going to go to Laura, because Laura was actually one of our pilot sites and has actually used this assessment tool in her pediatric practice, and then implemented subsequently some of the tools from the toolkit. So she will tell you how this works in action. So Darren, why don't you take it away?
Thank you, Cindy. As you all know, this webinar is focused really on the assessing your practice part of this to implement best practices related to health literacy. But as Cindy noted, this assessment is part of a more comprehensive toolkit to implement health literacy universal precautions. And we expect that the entire toolkit will be available in the next month or two, and we'll have information at the end on how you can get the entire toolkit. Today we're going to focus on the assessment and kind of how that can help you to make changes in your practice. A little bit of background on the toolkit. We structured the toolkit as what we sometimes call a change package, or a set of strategies that one can use to improve the care you provide in your practice. And the structure of the toolkit is on this slide, where we start with the path to improvement, and the toolkit will walk you through forming a team, assessing your practice, and raising awareness in your practice. The assessing your practice is what we're going to focus on mostly today. Once you've assessed your practice, we've put together a set of tools and strategies focused on 4 key drivers of care for health literacy universal precautions. And we've labeled those as effective oral communication, effective written communication, self-management and empowerment, and supportive systems. Here you have the list of tools in the toolkit. And again, these slides will be available to you, so don't read through all of those right now or take notes on that. As you can see, we have 20 tools, and they cover a lot of ground. Each tool, you'll find an overview, a purpose, action, and a way to track your progress. And throughout the call today, we'll give you previews of what some of the tools look like, but we're mostly going to focus on kind of the experience of the assessment and how that leads to action in your practice. So the question came for us, we've got all of these tools, but where should a practice start? And so we created Tool 2, which is a practice assessment, and we built this upon work of Rima Rudd, who had developed a tool to assess health centers. And we recruited her to be part of the development of this toolkit, but then further refined her assessment and customized it for primary care settings. Here's an example of what the health literacy assessment looks like. And let me just walk you through this cut and paste from the top of the page. The assessment has several items which we ask members of the practice to rate the practice. And they rate as either done well, our practice is doing this well all the time, needs improvement, we do this but we could do it better, or not doing it at all. And then we've rated each item on the level of importance. So those items that receive 3 stars are probably going to be the highest impact items, or things that are really important to address early on that your patients will really notice a difference. We think we wouldn't have put items in here if we didn't think they were important, so the lowest score is still called beneficial, but we wanted to have this prioritization to help practices decide what they could work on. I'm going to walk you through an example of how this might work. Here you have, if I move down to item 37, the item is our staff reviews medications with patients annually and after any significant medical event to ensure concordance between patient and clinical recommendations. And as you can see on this slide, the other component is we link you right to the tool that can help, which in this case is a brown bag review of medications. If you link to that tool, you'll come up to a page that looks like this, where it walks you through what is a brown bag review, what's the purpose of it, and then the action. What are the things that you need to do to implement an effective brown bag review of medications for your patients? Here you can see on this page we're starting to deal with one of the most common barriers that came up as we were testing this tool, and that is figuring out a way to remind your patients to bring their medicines into the practice. A lot of practices did not have patients that were used to doing this, and so they had to implement a process and think about how do we remind our patients to get this to happen. I will say that this particular tool, the Brown Bag Medication Review, led to very eye-opening testimonies from our practices. We had one practice try it with just 5 patients and found that 3 of the 5 had medication errors or inconsistencies between what the patient should have been taking and what they were actually taking. Another practice had about 8 out of 10 of their patients had at least one problem, and some of the patients had very important problems. One had 2 bottles of warfarin or a blood thinner and was taking pills from both when they should have been taking pills from one. So it was extremely striking to me in interviewing practices and what they were finding just from using this one tool in the toolkit. So that's all I want to say as a way of introduction to the toolkit and the assessment. For the rest of this presentation, I'm going to go back and forth with Laura. And Laura, as Cindy mentioned, was one of our practices that participated in developing and testing this toolkit. And what I'd like Laura to do is take a couple of minutes and just tell us, Laura, what it was like to use the assessment in your practice. How did you set it up, and what sort of insights did you give just from the assessment process in general?
Thank you, Darren. I'd be happy to. The assessment was really a great opportunity for our practice, and we are both a residency-based practice and have faculty providers on their own. But it was a way that we could gather as a group of people within the practice at the early beginnings of forming a team and go through this assessment together. I think if we had had one person fill it out, we would not have gotten all the rich information that we did out of it. So it served for us to both be an educational process, making us aware of things that we could be doing, weren't doing, but it also really helped us be truthful about what we were doing, making us face what we weren't doing a good job on, maybe also making us congratulate ourselves on the things that we may be doing a good job on. So we sat together as a group, and we brought a person from kind of each stakeholder, each person in the practice in the areas. We had somebody from the front office staff. We had one of the interpreters. We had a resident involved, a nurse involved, myself as the physician champion. All did this together and went through the questions together. We had contemplated whether we should do it individually and then get together, but we decided that in the interest of time that we could have those same discussions as we filled it out as a group. So it served a number of purposes. One, some team building and the beginnings of forming our team to work on this, but also really then to have each person that a patient may touch in the process look at the areas and the various questions in the assessment. Once we finished with the assessment, we realized that there were certainly many areas that were in need of improvement, that we did some things, but we didn't do them consistently with every patient every time, and that we didn't have certain processes, policies in place to make sure that they did happen every time. And we also realized that with turnover, one reason we might not be doing things consistently is that we did not have a method in place to train the new people that might come in and say, this is what we do, this is what we use. So it was a great opportunity to gather a whole lot of information about ourselves and our practice.
Great. Thanks, Laura. Oh, go ahead.
I was going to say at this point, Darren, if you wanted me to talk about that we've used practice assessments in the past around our care, our system of care with asthma or our system of care with ADHD or something like that. So I approached this as, what is our system of care, so to speak, for health literacy? What is our system in our practice around building capacity for patients to navigate, as the definition alluded to, through the healthcare system and get what they need? The thing that I really liked about this assessment was that it took us directly to the tools, a link to the tools that would work best for that particular question, and also the level of importance. The assessments I've used in the past have not had either of those things. So you may have assessed your practice, but then you hunted kind of on your own which tool might help you. So I thought that was just a really great added benefit for this particular assessment.
Great, thanks. I think the other thing that comes out as you're speaking, Laura, that I think reflects how you approach things in your practice, but also how we tried to design the tool, is that the tools in the toolkit should lead to implementation so that it becomes part of the fabric of your practice, not that it's sort of something that you read in a magazine and try it here and there, but that we think through implementation on how this gets done for all the patients every time they need it. And maybe as we go through some of the things that your practice worked on, you could comment a little bit about how you're thinking about that aspect of this work.
I'd be happy to. I think, too, to stress just the whole team piece of this. If a practice manager or one person filled it out, I just think you would lose some of the benefit to doing this assessment. So I want to make that encourage people to do it in a team form.
That's an excellent point. And when we did the testing, Laura was one of 8 practices that tested implementation of the toolkit, and we found that the practices that were most successful in making progress implementing these changes had a team, and they had people on the team from all parts of the practice, physician leadership, mid-level provider leadership, front desk and clerical work, nursing leadership. Everyone was integrated in the team for those practices that really made progress. When it was just one person, it was much harder. So let's walk through a couple of these examples, Laura. And what we've done here is we selected, when we did the testing, practices like Laura's went through the assessment and identified things that they wanted to work on. And then we asked them to focus in on what are the 5 things that you want to do the most, that you think are going to have the most impact for your practice. And I've selected a few of these to have Laura share about. One that Laura's practice worked on was the teach-back method. And here you can see item 10 in the assessment is written as staff ask patients to state key points in their own words, i.e. the teach-back method, to assess understanding of care instructions. And if a practice decides that they need improvement or that this is not done, they can click to the teach-back tool, which will take them here and describes, what is the teach-back, what's the evidence behind it, what is the purpose, and then it walks through the action. How do you actually implement the teach-back method? And Laura, why don't you tell us a little bit about what happened in your practice when you guys tried to tackle this one?
Okay, I'd be happy to. And again, exactly what Darren said is when we did the assessment, we found that answering this question was certainly one of the areas we wanted to work on. Again, that assessment helped us prioritize what things to start with, because you could get overwhelmed thinking about 20 tools. So we started with the things that we thought were most beneficial, and it was a great roadmap for us in our busy setting, going through the actual tool itself. So when we chose this tool, we got together and we actually read the tool, which is always a good place to overview the purpose. We learned about some of the ways that we could learn how to do teach-back using a video. There's a PowerPoint on teach-back included in the toolkit. And so we went through that, and we chose one of our residents to test this on. And I would encourage practices and people out there to remember that when you want to try something, test it small. You don't have to test it on 100 patients. You can test it, as we did, on one resident in one continuity clinic, meaning her little private practice. And she has about 5 or 6 patients in that afternoon, and so she tested it on different types of visits, well, child checks versus an acute visit, but she was able to do that. And what she found was a number of fun and interesting things, and what she found very beneficial. One, she said it really changed the kind of the relationship between she and her patient. She started it at the very beginning of the visit because she wasn't sure how much time it would add to her visit, and she was afraid it might add too much time. So she just started breaking down what she was doing in the visit into little pieces and would ask the mother back questions about, what have I just done, or what have we just talked about in her words, and tried to see if the mom could answer her back. And then she also tried it just at the end of a visit. So what she found after just a couple of visits was that it worked best for her that if she thought about restructuring her visit around teach-back and approached the visit a little differently with teach-back as one of the key things that she was going to do in that visit, just as important as looking in the ears or checking the child's development, that one of her fears, which was it would add too much time to the visit and slow her down, really didn't occur. She felt that it added a little bit of time, but that was more a learning curve in learning how to do a new skill, which teach-back was a new skill, and any time I think we learn a new skill, it's going to slow us down a little bit. And she compared that to just doing the teach-back at the end of the visit. And so for her, it worked best to restructure her visit, and so that she used teach-back almost at multiple points through the visit rather than at the end. As we have more recently tried to expand this to the other residents, and we're going to start teaching it to all the residents and the faculty, I think we'll find that some residents will restructure their visit, some will do it at the end of the visit. And again, I think it just really illustrates how a wonderful change idea needs to be adapted at the individual practice level. And while the idea is applicable across, how it may look for you in your practice and your patient population may look slightly different, but that the principle is in place. So I'll stop there, Darren, and see if that's enough information on the teach-back tool.
I think that's great, the way that you tested it with the resident, and now that you're spreading, once you've got a little experience under your belt. I think, and that's what we advocate for in the tool, is, like Laura said, to start small, pick one patient of the day to work on it with, because it does change the way we communicate with our physicians. It does change the way physicians communicate with their patients. As soon as you start to think that you're going to use the teach-back, you explain things differently. All of a sudden, you're holding yourself to a higher standard because you actually are expecting the patient to remember it. So I think it's a new way of communicating for a lot of clinicians, and it does take some testing. You did make the point about it. It slows us down when we're trying something new, and I think a lot of people have said that about the teach-back method, but anyone who's tried it over several times learns how it kind of just fits into the way they do business, and it becomes not something that takes a lot of extra time once you kind of get used to using it.
And that's, I think, true of any new skill that we're learning. When I learn how to look in ears, I'm going to be a lot slower at the beginning than later. And I think if we help our colleagues and ourselves realize that that's true of using teach-back, that it doesn't become a burden, it just becomes a new skill set that we're adding to the way we care for patients.
Right. Good example with looking in ears. I can remember as a medical student always assuming it was easy to look in ears, and it's not.
That's right.
I will mention that the teach-back is one of the most, if not the most popular tool in our toolkit, and just about every practice wants to work on that. It's not easy, but we heard over and over again that it was very valuable for practices and taught them a lot when they were learning how to use it. So let's go on to the next part of the assessment. And under encouraging questions, we have a few items in the assessment instrument, we've got them here on the screen. Staff encourages patients to ask questions by using these words. What questions do you have instead of do you have any questions? The answer to do you have any questions is almost always no. And so we need to think of better ways to get patients to ask us questions. And do we create an environment for our patients to ask questions and to get involved in their care? And do we encourage patients to write down their questions while they're waiting for their appointment? This also serves the purpose of setting the agenda for the visit. And all of these items in the assessment lead to Tool 14, which is encouraging questions. And this was another area, Laura, that your practice decided you could do a little bit better. And why don't you tell us your experience with this? Before you do that, let me just show the tool on this one. On encouraging questions, again, we provide the overview and the purpose. We think that there's a lot of value to this. There's a lot of research behind the general idea of encouraging questions and facilitating dialogue. In the action part of this tool, we direct people to several programs that are available for free, such as the Ask Me 3 program or Questions Are the Answer program at AHRQ. And these are very easy to use programs that can be rapidly implemented in a practice setting as a strategy to get all the staff on board with creating this environment. So I'll stop there, Laura, and tell us what you guys worked on.
Okay, so again, in the spirit of testing small, we chose one thing to do in the larger concept of asking encouraging questions. And I will say again, I don't know that we would have done that had we not answered this assessment as a team and having multiple stakeholders, so to speak, at the table. And what we decided to do was, after reading through the tool, to have the checkout clerk ask when she was checking the patients out, did you get your questions answered? And we had her test this, and she was very interested in doing it. And the other thing was we tested this when we were short-staffed. So, there's always, we can't do this now because somebody's sick or we need to hire somebody, but this just needs to be how we do our work in the future, is to test things small, whether we've got enough staff or not. And so this was on an understaffed time, and she did it one afternoon for the initial test, and she asked not every patient, because she forgot a couple, and she kept just a very simple little check sheet by her desk, and she wrote down whether she asked the question or not and what their response was, yes or no. And she found a couple of really interesting things. She said that the patients' faces kind of lit up a little bit when she was asking this question, and she said it changed her relationship with them from somebody who was just checking them out to more of a relationship, to somebody that actually cared, and it, she felt, gave her more satisfaction in what she was doing, and she felt that the patients were really pleased when she did it. Of the patients that she asked that, she did, at least in this initial test, get a yes answer to did you get all your questions answered. She didn't get any no's. But as we tested on other days and tried and started to expand, she did get a couple of no's. And what we discovered with that was, well, if you're going to ask the question, you better have a process if you do get a no. So that led us to figuring out, okay, if somebody says they didn't get their questions answered, what's our next step? Do we call the triage nurse back? Do we call the doctor's nurse that the patient just came from? So it helped us go on to the next step in the process. But probably one of the most gratifying things that came out of it was that the patients really seemed to like it, and the discharge clerk said it changed her role. It made her a part of caring for the patient rather than just checking them out.
I think that's a really good point, and I think that's one of the reasons I wanted to talk about this one with you, Laura. I remember talking with you about having the discharge clerk involved, and I found that in this issue of health literacy, it helps to have everyone on the team engaged in this issue, and it really makes the job of all staff members more important. And when you told me about the experience, I was really impressed how much this can change the job description for someone and how they feel about their job.
I really think that it really helps us to become patient-centered, and that we all have a role in patient's care, not just the doctor or not just the nurse. But I think you're right, and I think that was pretty eye-opening for the person that carried out the tests at the checkout. We went on to test this as well with the interpreters and with we have an immunization room, so that at multiple points, at least at 3 points in the encounter, possibly more, they got asked, did you get your questions answered? And we did, even during the testing with the interpreters, catch a very important misunderstanding, and the interpreter was able to go quickly get the resident physician right then and come back in and re-explain, and then use teach-back again to make sure that everything was understood. But it really did change it changed the role of the interpreters and everybody, that, more a part of the care rather than just somebody who's supposed to interpret for the doctors or the nurses. Yeah.
I wanted to also follow up on a comment you made at the beginning of this that you and I have talked about before. It was really striking when you filled out the assessment how important it was to get several different members of your practice filling it out, and that it led you to think about different tools to implement. Can you just talk for a minute about that, and how did it change the way you thought about this work?
Well, for one thing, one way it made us change was that the tools and being directed towards them made it not so overwhelming. It gave us a place to start. It really gave us a roadmap, and we didn't feel like we had to do all 20 tools at one time. And so we found that having that guide, we may not get to that 20th tool for 6 months or a year, or we may find that we don't need to use that tool because that piece we're doing very well. But it really helped us to prioritize and get us started, because I think when people try to improve things and they might know that there's a gap or they might know there's an issue, getting started, even after you've formed your team, is sometimes a real barrier and a roadblock. And having this toolkit already there, that I didn't have to recreate the wheel, we didn't have to brainstorm necessarily to get started. We could just kind of get directed to something and jump in and start testing. And with each test, we gained more confidence that this is the right thing to do, that it didn't add a lot of extra work, and that it was actually fun and changed not only our relationships with our patients, but our relationships with each other as colleagues, breaking down the silos in the office, that front office versus back office, the physician versus the nurse, and really helped us, I think, to move towards becoming a care team rather than individuals caring for patients. And I think I was surprised by that effect of the assessment tool in terms of the morale, and have gotten more of that as we've talked about it in clinic. The people that were involved in that assessment will say, well, let's go back and look at the assessment and see what else we need to do. It's just really been a great roadmap for us. I don't know if I spoke to what you were asking me, but
yeah, exactly. That's perfect. Let me move on to the last area, Laura, that we were going to talk about today, and this is in the area of helping patients set action plans. And in the assessment, we have an item that says, clinicians work with patients to discuss healthcare priorities and develop action plans to promote behavior change. And this is one strategy for self-management support of setting action plans that often isn't included as part of health literacy, but we really found that this is an important step for helping patients take action once they've understand their medical problem and what options they have to do about it. And so we added this strategy in this tool, Make Action Plans, and we found that it was popular with practices as a way to kind of take the next step past just ensuring knowledge, but helping the patient take the right actions. And as part of this, we link practices to information about how to set action plans, videos on how to set action plans, and even a form that can be used in the practice. And this was one of the tools that you decided to work on, Laura. Why don't you tell us about your experience on this one?
Well, we wanted to work on this tool, one, because based on the practice assessment, it led us to this tool. That was one reason that we prioritized that. And we were familiar as a pediatric practice with a type of action plan, the asthma action plan, and we had been working on trying to improve our delivery of the asthma action plans. And so we were familiar with that, and this action plan was is a little bit different in that, as we talked about, I think, at another time, that the asthma action plan is kind of if this, do that type of a plan, whereas this was more of again, a shared process between the patient and the physician in terms of we incorporated teach back. We could write down on the action form what are some of the things, with the three things we talked about today, the three most important things. So it incorporated teach back in that as well. It involved everybody. We involved the attending physician that tried this one. She used it on a 10-year-old young girl and her mom, and she was able to involve the 10-year-old in the process. What do you think you can do, and what do you want to try and work on? And as you alluded to, there's the piece of how confident the patient is that they think they can work on it. For us, we kind of did both the parent's confidence level and the child's confidence level, and for us, we always have both of those factors to consider once a child gets to a certain age. It was less rigid than an asthma action plan, so it's a little bit more fluid, and the patients, what Dr. Ramkumar, the attending that tried it, really liked was that it really got the little girl involved more so, she thought, than if she had just been using teach back with the mother, but it actually got the child involved as well. And so she had a very positive response from herself, feeling like the visit went differently and better, but also she thought that the mom expressed, just something much more grateful to go home with something in hand that she could refer to, and not necessarily an educational form, but specific to them, to what they talked about and what they were going to plan to do for the next week or the next 2 weeks around the issue, which I think is a little bit different than just handing educational materials, or even if you use the educational materials in the visit, the action plan is more personalized even than that, and so it was, again, a very positive response from both the patient and the physician. And I'll tell you, we stole this idea, and we even tested it on the inpatient service a little bit differently, and we modified the form, but talked about action plans with the families for the next 24 hours, and the goal for your child for the next 24 hours, and what do you think you can do, and sometimes it was what we're going to do, and sometimes it was what the parent could do for the child. So I hope that was okay to all the people that developed the tool, but it was great for us because we tested it on the inpatient unit as well, and the parents really liked it on the inpatient unit as well.
That's great. That's great to hear. Well, excellent, Laura. That's a great summary. And in the time that we have left, I think that folks have been submitting some questions online. And Cindy, do you want to kind of go over some of the questions that folks may have brought up as we've been having this conversation?
Yes, we've had a number of questions typed in. I'm going to take the first one, actually, which was, can any practice use this tool, or do you need ARC's approval? And once these, the toolkits are available, and we'll give you some more information at the end, it is free to use by anybody who wants to. It's what we call putting it in the public domain, and you can download it, share it, access it at any time, etc. So another question that we had was whether about other practices where we had implemented the tool. Darren, I know you had a range of practices, and in particular, the questioner was interested in hearing about busy private practices as opposed to teaching practices. Can you describe a little bit some of the other settings that it was tested in?
Yeah, we tested it in, we had busy private practices, we had a community health center, we had a free clinic in there. It was about 4 or 5 of the 8 practices were private practices in the community. And, all practices faced issues of being extremely busy and having difficulty implementing the tools. What we had requested people to do is to take 3 months and try and implement 5 tools. What we found is that was a lot to do in 3 months. And generally what we got is that practices made good progress on about 2 tools within 3 months and maybe got started in their thinking on the other tools. But we found that private practices, that were interested in this topic took this and ran with it as much or more as anyone else. We had one private practice that started, the practice manager became kind of the champion, and after a couple of weeks, she had the entire staff doing teach-backs with one another as the way that they communicated in their practice. And they really embraced this because they saw this as something very important to their patients. So I think that in the small test of 8 practices, we wanted to get broad representation, and we found that all types of practices could use it. Again, I think the main barrier is not getting enough buy-in from all parts of the practice. So the leaders need to be bought in, but you also need to bring into your team folks from not just physicians, but nursing staff, clerical staff, phone staff. Everyone needs to be involved.
Thanks, Darren. And that sort of leads into the next question that I want to pose to Laura. And that is, questioner asks, small tests of change are a great approach. How did you get the rest of the clinic to adapt these new practices to their work? Did everyone commit to change if a small pilot was successful?
And when we are implementing some of these practice-wide, because we have the resident side, but we have the busy faculty side as well. So we kind of have a hybrid where we have a busy practice on one side and then the resident. And so what we have done is as we are implementing, and Darren's right, we were able to do a lot of testing, not get fully implemented in 3 months. So we are continuing to spread it and implement it throughout. And so we are continuing to test as we implement, making broader and larger tests. So on the faculty side are involving 3 faculty at a time, and on the residents, we are now spreading it throughout all 32 of our residents through some teach-back training, and so that's what we're focusing on first because we think that that's the biggest, so to speak, bang for our buck in terms of the beneficial to the patients. And I would encourage people to continue even in the implementing. You keep doing PDSA cycles, you keep testing small, but they get a little bit larger each time, and you test it under different conditions on busy Mondays, on days when maybe certain physicians are not there or certain physicians are there. So as you spread, continue testing, and don't just say, okay, on July 1st now everybody's going to do it after a couple of tests. We use the PDSA cycle as we implement it as well. And I will tell them that we're not fully implemented yet. It is a process that we're still continuing to do.
Thanks, Laura. The next question actually is for me. It asks, does this assessment relate to the new CAPS health literacy item set? And for those of you who are not familiar, CAPS is a family of surveys that assess patients' experiences with care. And there are facility-based surveys and there are ambulatory surveys. And we recently released a supplemental item set for the surveys that we call the clinician group survey that rates practices and primary care physicians. And we came up with a new set of items specifically looking at health literacy and trying to provide specific quality information that could be used for quality improvement, so to get a lot more detail about the kinds of things. The relationship to the toolkit and to the assessment is that the CAPS item set is part of the toolkit. It's one of the tools in the section that talks about getting feedback from patients. Another question here asked in terms of whether or not these interventions have correlated with improved CAPS scores. So in other words, is a practice going to score better on CAPS if they have implemented these interventions? And I must confess that that is our next phase of research with this toolkit, is to try and have some practices implemented and look and see what actual impact it has both on CAPS scores and other measures. I'm going to go back to an issue, Laura, that you raised earlier, which was about working with interpreters. And you did mention that you had included them in the teach-back, but before you discussed that, there were several questions about what you felt the issues might be with using interpreters in conjunction with teach-back. Did you have any additional reflections on that?
I think that the use, and I think there are, when we started using interpreters and trained residents and trained faculty and the practicing pediatricians on how to use the interpreter, there's a little bit of, and I'm not an expert in this, different thought out there about, the word-for-word kind of interpretation, so that you try and get that flowing, versus where I've seen some more cultural mediators, that the interpreter becomes more than just an interpreter, but really helps culturally mediate that as well. So we're looking into broadening a little bit of the scope of the interpreter in terms of kind of maybe rolling into that more cultural mediator role, not just interpreting, so that they can help us with some of those issues, so that the teach-back is done in such a way that does take into cultural differences and beliefs that we may not appreciate as the provider who's not a native speaker or from that culture either. So I think that if you work with interpreters, I think having their input on how to implement teach-back and how to use it would be just key. And we initially, when we started thinking about this, didn't at first include an interpreter, and then we said, wait a minute, we need to have an interpreter because they're the ones that are going to really be helping us do this teach-back so much. And so what are the issues with teach-back for the interpreter, and how do they help us use plain language and using simpler terms and not so medically complex terms. So I'm not sure if that answers your question, but it was really helped us look at kind of the role of the interpreter in the clinic a little differently than maybe we had been before.
Yeah, well, and it sounds like, in terms of your health literacy team, that you had kind of rethought that as you were going along.
Yeah.
The interpreters. That's great.
And they thoroughly enjoyed it, I will say, being involved.
Great. I am noticing that we're sort of at the top of the hour, and that probably some people have some other meetings to go to, but we will be continuing to answer questions for another 15 minutes. You will see on your screens that we are aiming to release the full toolkit. It says by April 2020. I think Darren and I are both hopeful that it'll be well before that, but we're in a little bit of a limbo land in that we are required to have clearance from the Department of Health and Human Services before we can put this out. But it'll be available on both websites, both the ahrq.gov website, and that will have a a PDF version that will be compliant for accessibility for people with disabilities. And at the nchealthliteracy.org site, there will actually be a web-powered version of this. So both in terms of how you navigate through the toolkit as well as linking to the many web resources that are contained in the toolkit. So for those of you who do have to go, and we hope there aren't many of you, just wanted to make sure you had that information and to remember that immediately after the webinar, the actual assessment tool will be posted on the Your Voices website. So with that, I am going to go on to the next question, which I think of as being kind of for Darren and me, which it boils down to, we talk about health literacy universal precautions, but what does that mean in terms of the individual? Should one test individuals for health literacy or not? And there is a debate in the field, but I'm going to let Darren kick off on a response to that. If you
okay. I think that in our toolkit, we don't advocate screening individuals for health literacy because we've taken the universal precautions approach. At this time, it's not clear that testing individuals for their health literacy helps us know which people are going to understand and which people are not. What we found is that a lot of people, regardless of how they might test, can have trouble understanding things, and trying to screen and tailor our care based on that may lead to may not help us as much as we think it should. There are people out there who are trying screening programs, and I think we can learn from that, hopefully. But to me, if I'm a clinician sitting in front of a patient, regardless of what I know about their background, or even regardless of what they score on any given test, I need to find out whether they understand or not. I need to do something like the teach back and have them say, well, tell me what you're going to do when you get home. So in my practice, I haven't, and we've tested thousands of people for their health literacy in our practice, and as mainly part of research programs, and have not found that doing that makes us want to treat them differently. I don't know, Cindy, what do you think?
Well, there is a debate out there. My take on it is that the majority of people do not recommend individually testing, that there's a lot of concern about stigmatizing patients, and especially those with limited literacy may actually run away from the practice. However, there is some research that shows that patients don't mind taking some of the very abbreviated screening tests, and that it's important to be aware of individuals' health literacy so you can tailor things accordingly. So, there is both sides of the coins are argued.
I can say we just had a paper accepted for publication where we looked at, how we asked people their opinions on being tested, and we found that 90% actually thought it was probably a good idea, that they thought their doctors should know how well they understand things, but 10% really didn't like it. And most things in medicine, if 10% of our patients aren't going to like it, we ought to think twice before we start applying it to everybody. And we needed some good evidence that it helps us.
Okay. I have a question now for Laura, which is, did you find a significant increase of time and cost?
In the visit? I think time to the visit?
I think that I'm interpreting that because that was all that was written. But yes, I think that in terms of time in the visit, but you might also want to address sort of the cost of the practice of just doing the assessment and undertaking this quality improvement activity.
Certainly in terms of the time of the visit, and that is always a concern when we have implemented some new things in visits, whether it's certain screenings or whatever. What's it going to add to the visit? Well, what we have discovered is that if we'll measure something, then that helps with perception. If we can, so we'll do we'll do some cycle times and say, did it really add 10 minutes to the visit, or did it add 3, or did it add 30 seconds? And we do find that obviously during the learning curve phase that there is some time that gets added to the visit, but that overall it wasn't a significant amount. If it was maybe 3 minutes, and even if you see 40 patients a day, that you could say 3 minutes for 40 patients, that's 120 extra minutes. That could be a lot. But if you probably aren't going to do it on all 40 patients exactly. It's not going to take the same amount of time, and so there is a small time cost, I would say, that comes in when you're implementing, but you can counter that with how many callbacks you get to the practice. I didn't understand this, or I forgot to ask this, or that, oh, by the way, when the physician is reaching for the door, or the provider is. So I think there are some ways to look at it in terms of, yes, there was this initial investment, but did it save us in these other areas? And you can actually do some simple measurement around that with just tick sheets. How many phone calls did we get back? But the bigger cost, I think, comes into if the patients aren't doing the care that we think they need to be doing. Are they returning for, complications because they didn't do the care, or other things that because they didn't understand? What is the cost of that? So for us doing the practice assessment, the cost was I took everybody out to lunch because I wanted it to be a fun time. So that was just a small cost, and it wasn't a big team, and I didn't let us go anyplace expensive. But that's something that certainly I think you could do to help by engagement and buy-in initially, and when you're trying to do this, is do it over a meal and make it a good experience for everybody if you can, even a little potluck. So to me, there was not a big cost. It was actually, if you can measure the cost of the things that you are avoiding and preventing, I think you're going to come out with cost savings rather than increased cost.
Great perspective. Thanks. The next question I suspect both Darren and Laura can address, but I want to take a first crack at it from the layperson perspective. It says, would you recommend using teach-back method on proficient patients? How would these patients respond? And I wanted to respond by a personal anecdote of how I took my husband to have a wisdom tooth removed the other week, and they were very assiduous at giving us instructions of what to do for home care afterwards. Several different people went through it, but it wasn't until I actually initiated my own teach-back that I discovered that I had misunderstood exactly what we were supposed to be doing. And that was in a relatively low-stress healthcare situation. In higher stress situations, you could expect proficient patients to do as poorly as anyone else in terms of really digesting the information. So that was my crack at that question. Darren or Laura, do you want to add anything?
Go ahead, Laura.
Oh, okay. I was going to say, we are looking at that now. Probably where we've gotten a few comments about that, I'm working on health literacy with my healthcare system, was from some of the home care nurses, and saying that with some of their elderly patients, they got some pushback about, I'm not a 2-year-old, you don't have to treat me that way. And I think that's part of us learning how to do this in such a way that it's not, threatening, that we aren't talking down, that we aren't making people feel a certain way. So I think that's part of the learning skill. I would give you the same anecdote that you described,
Cindy, that with some of my own family health care issues, when I'm tired, when I'm sleep deprived because my child has been sick or something, and the stress of that I haven't remembered. And now, what did they say? What was I supposed to do? And so I think that your experience is similar to my experience, and that hopefully that if we learn to do it well, patients will appreciate it, not be offended by it.
Yeah, and I would add that the tool on this gives some language and some examples of how you can do this in a way that doesn't sound like you are expecting them not to understand. It's in no way demeaning. It really emphasizes that I'm checking myself because I need to make sure that I'm being clear, and I may not have done this well. Darren, did you want to add in, or should I go on to the next question?
I think Laura hit the nail on the head with this, and you did too. We just need to learn how to communicate it better. This is not a condescending practice. This is just regular old patient safety. And even actually very proficient people actually do this on their own. I've met people who say, okay, Darren, let me just make sure I've got this right. This is what I'm going to do. So we just need to change the way we communicate with our patients and change their expectations. It's not about condescension.
Okay, question for Laura. Which tools did you practice implement to more effectively engage patients during phone calls, e.g. reminder calls, triage nurse calls, etc.? And how was implementation different for phone versus person-to-person encounters?
Well, I might have to defer that one to Darren, in that we tested, and we've 5 tools, and phone wasn't one of those that we tested. And so as we continue to work on this issue, I know we will get to that, but Darren, I would say, was there any of the other practices that specifically worked on the phone communication?
I'm not sure that I completely understand the question. I think that I don't think any practice implemented it to the degree that they got a sense for how to do this on the phone, say how to do the teach back on the phone. In terms of some practices evaluated their phone systems from the perspective of their phone tree, and how complicated is it for patients to get in touch with them, and do they understand that part of their practice. Practices who worked on that found that they needed to take a fair amount of time to understand how their phone system worked, and probably the most powerful thing that practices did is have someone from the practice call. So call as if you're a patient and find out what it's like to try and get through and to get a question answered. And when practices do that, the ones in our study, they were surprised at what it was like to call a practice.
Great. We are at 4:15, but because we have so many wonderful questions, we're going to just take one or two more, go a few more minutes. So if you've still got an appetite, we'll keep going. The next question I wanted to throw out is for Darren. Is there a numeric score at the end of the assessment? How does one score oneself on it?
Excellent question. We debated that. We decided to not do a numeric score because each item in the assessment has a level of subjectivity to it, and we're really asking practices to self-evaluate and say, well, how are we doing here? And to give it a score of 1, 2, 3, and then to add it up and give you a number at the end, I don't think it's a valid reflection of the quality of care you're providing. So the assessment in this case is really meant to go item by item and think through, and then go through a prioritization process. But it's not set up as a scoring test where you could do the assessment, get a number, and then do it again later and get a different number and decide whether you've improved or not. We just didn't think that this by adding numbers to the assessment, we thought it would give people a false sense of precision on what we're measuring.
Okay, I'm going to race to another question, try and fit a couple more. Is this tool utilized for a facility that does not have a health literacy program already, or could a facility that has a program already benefit from this toolkit? And Darren, I have a few thoughts, but I'm going to give you the first crack at this.
I think the answer is either of those situations, this toolkit could be valuable. So certainly valuable for an organization that hasn't thought about health literacy yet, because it provides you a good place to start. I also think it's probably valuable for organizations that have been thinking about health literacy, because it will bring up some new ideas. It will give you a fresh perspective on what we think are the key strategies to implement.
And it has a huge number of resources connected to it.
Yeah.
I absolutely agree.
And if I could throw in too, I couldn't agree more that even if you are doing things on health literacy, when we look at our systems of care, we often think that we're doing a really good job, and we are. We're working hard, but we don't really have a good measure. And using this assessment actually gives us a little bit more objective information. We think we're doing these things. Let's see if we really are doing these things. And so I think it could easily be used in an organization that's already working on health literacy. Like you said, new ideas, new resources, stealing from others, so to speak, and new things to try.
Great. And a question back to you, Laura. Questioner asks, it would be curious to know if that one, well, that's what it says, that if one asking to the patient, do you have any questions, creates a more comfortable environment to really ask questions. My point being, was there an increase in questions within the following visits? So do you think actually asking that differently makes a difference?
So if we're talking about kind of encouraging questions, that would be a good thing to measure and look at. Did we get more questions? And I think they're referring to when we ask, did you get all your questions answered? I think that, I don't know that we know yet if we ended up getting more questions the next time, or if it just helps people feel more comfortable that if they do have a question, they're going to feel freer to ask it. I don't know the answer to that yet. We'd have to actually do a little before and after measuring of the number of questions, but it's an interesting thought and question. My hope from our early response is that it really built more of a relationship, and the more of a relationship that is there, I feel like the more likely the patients will be to feel free to ask the questions. Again, I don't have a way to prove that yet, but that would be my hope.
Great. Well, we have gone 5 minutes over your promised release time, so we will not infringe any longer, but I do want to throw this back. I believe, Julia, you had a few closing comments?
Yes, my closing comments, first of all, are to assure you that the recording of this webinar, all of the presentations, the assessment tool, and some additional resources will be available on our website after the webinar. And because you gave us your emails when you registered for the webinar, we will be able to send that information all out to you by email. The second thing is that we got many, many questions, and Cindy and the panelists did a great job of answering quite a number of them. And we will also be having them take a look at some of the other questions that we didn't have time to get to and sending a selection of those answers to you also by email. The other thing is that we'd like to know what you thought about the webinar, and if there were things that were particularly useful to you, and if there was anything that you thought we could do to improve. So please fill out the satisfaction survey that is going to be sent to you in an online link, and that will be very helpful to us for future webinars. And then finally, we have another webinar scheduled in March, which will focus on translated materials, how you go about getting them produced, how you go about finding people to help you do that, with some really excellent presenters on that, and it will be on March 11th. And then finally, you can contact us if you like by going to our website, which is at www.diversityrxconference.org/yourvoice. And not only will you find the link for this webinar, but you will also find links for other webinars as well as the recordings and information about some of the other educational activities that we do. So we'd be very happy to have you participate with us again. And thanks to Cindy for her terrific job in organizing and moderating this session. Thank you to both of our panelists who did a terrific job. And thanks to all of you for coming. And we hope to have you with us again on another webinar. Bye-bye.